always, delay some stuff, but
We are
let's
live
be.
now.
Oh, that's good.
Okay, let me share the screen. We can go. Okay, so Dr. Maya Nasir, it's all you.
All right. Assalamu alaikum and congratulations to all of those joining as new residents and interns. You have achieved this milestone. We are so very proud of you. Your families are proud of you. Now, let's make the best out of this. This small talk we have assembled for you is more of an informal intro into the healthcare system, I'm hoping. So let's get started. My piece is going to be chatting, sharing some experiences of softening the blow of the social piece of residency, the social, the interactions, the communication, how to be a star intern with your mannerism and your presence. Next, please. First of all, I want you all to know your worth. You are needed by the system. This is a two-way street. I sometimes get this attitude, this down, almost like a Eeyore personality from my interns, as if they are being given a favor. No, this is your right. This is a need. By 2030, the US healthcare system will be over 100,000 short in physicians. And be proud, we are part of a 250,000 personnel group of international medical graduates who are supporting this wonderful country, this healthcare system. So stand proud. Next slide, please. Now, the basics of scientific ethics, medical ethics, patient interactions, families' rights, all of that will be ingrained, will be taught to you day after day, starting your first day in residency. So I will leave that for your programs. That's going to be an intense course. I don't want this to be taken as your ethical training. No, this is, again, the soft transition of socialization of medicine. The art of medicine is what we'll be sharing in a little bit. Slide. Now, when you walk into a room, what is the first thing people see? People see you arrive. And let me tell you, they should, the families, the patients, your colleagues, they should see you arrive. Be clean, be tidy. Some of my colleagues who are working in the hospital will show you what a doctor should look like in a little bit. I'm on vacation, I apologize, I'm sitting in a hotel room. So be clean and tidy. Your white coat is your cape. I'm a pediatrician, so superheroes, capes. That is our cape. That is our responsibility. That is our magic wand. Your stethoscope if you don't have a white coat. And peds, sometimes we don't wear white coats. And if nothing else, have your ID badge. Prominent, lapel, not down on your pelvis, lapel. Modest. Now, modesty is defined by you. Be modest, but relatable. What does that mean? If you're practicing in the East Coast, West Coast, Florida, be with the seasons. If you allow it, you socially accept it, go with the seasons. 4th of July, be proud, red, white, and blue. Christmas, red and green. Halloween, you should see us pediatricians. We have costumes on costumes. I have 12 costumes. So that is my request to assimilate, still stand proud of who you are, where you came from, but relatable. Some of my friends, and I respect this from the depth of my heart, they like to carry on residency in shalwar kameez. Proud. I have a buddy of mine who went to Mass Eye near Harvard and, was proud of that. And we are so very proud of those accomplishments. If that is the case, I want you to ask yourself one question first. Are you going to be wearing shalwar kameez daily, or is this a choice day by day? You will be coming in Western gear 90% of the time, and that, in my opinion, is not acceptable. Have a conversation with your program director, with your chief resident. If it is a stand, if it is who you are, this is what you're going to do, great. But if it's off and on, then really think hard about it. If nothing else, wear a smile at all times. Wear a smile. Next, please.
Dr. Malik has his hand raised. Do you want to add something, Dr. Malik?
No. So, Amana, do you remember the example? Like, there is a guy who's a hemonc, he wears shalwar kameez and a cap, a Muslim cap. And same as the Sikhs, they wear the turbans. And in US, it's totally acceptable that if you're wearing that, but it has to be 100%. As Amana said, it cannot be like shalwar kameez few days, and then it has to be business professional. In my program, when I was training in outpatient world, like in a clinic, my program director wanted me to wear ties and shirt because these will be my patients for the next 3 years. And as I'm going to those patients, so if not in the inpatient or in the hospital, when you're in clinic, this is your office, and this is called as an office. So you wear tie and your white coat because these new patients are coming in and they are going to be on panel. I just wanted to add this. Thank you, Mana.
Thank you, sir. Now you've walked in. What is the next thing we pick up on? We pick up on your aura. So have a positive presence. After the presence, when you're approaching somebody, this is something as a mother doctor I'm going to talk to you about now. I'm a mama. I have children. I have a 22-year-old, a 17-year-old. After they see you, they sense you and they smell you. So those senses of smell, that smell that we get from, humans, it should not be overpowering. Let's not have Christian Dior and let's not have Sauvage from Johnny Depp that you overcome every other sense in the room. But cleanliness, this is important, and I don't want to sugarcoat it yet I want this to be a soft suggestion. Deodorant, very important. We have chemicals, hormones. You guys are scientists, physicians. We know this. We have juices. So for that, we must not just cover, but find out your strengths. There is regular strength and clinical strength. If you're on a 48-hour stent in the hospital, that poor diddly do 8-hour secret deodorant may not work. So go with that 48-hour clinical strength in the clinics. So know your strengths and your weakness, and let's help yourself. Now, I want to tell you 2 stories. We had a wonderful doctor from Pakistan, one of our brothers, and he probably was not aware of the deodorant story. So as a chief resident, it was my job to speak with him. And as my younger brother, then we had that conversation, easy. And then we had another doctor, let's call him Gulfam. This Johnny Bravo looking physician, again from Pakistan, very handsome, well put together, but his issue was the overpowering smell in the room. So let's be conscious of that. Dental hygiene. Remember, my brothers and sisters, especially in Ramadan, let's not give that gift of the woof to people. It's for each other maybe, but let's keep that dental hygiene. Keep a mouth freshener, alcohol-free if you must, and just swivel and spit if you want to. Now, this is a story of a cute little darling newlywed. We'll call her Dr. Janu. This sweet little Janu would wake up, make her food for the day, and come to work. Guess what? When you cook desi pyaz and desi onions and maybe some hing, that gets into you. That becomes part of your pores, and parents and patients will pick up on it. Pediatric patients will say it. Doctor, you smell, ew. But adults may not, but they may talk about it. So make sure these are little soft calls of socialization. Now, this is for my sweet brothers, my gentlemen friends. In the US of A, again, in Pakistan also, but kursi ki jung. When you go to the party, you lift that seat cover. Please do lift it. Kindly put it back, because when you come out and a nurse follows you or a female physician follows you, they will talk about you. You don't want to be known as that doctor or that provider. Next slide, please.
Yeah, I think Dr. Malik has something else to add.
Yeah.
I don't know. No, I don't. I think she covered it really well.
Okay, great. We'll move to the next one.
Now,
yes.
This is the other one. Some of us may have heard the song Eye to Eye. So eye contact. Without saying names, they're a good buddy of mine. He was once summoned to the chairperson's office for the reason of not make eye contact. It's supposedly modesty in our part of the world. But in America, eye contact is respect. So having a positive body posture, standing proud of yourself, open arms, leaning forward, and sitting on the stool in the office, as Dr. Malik said, your office is your office. They're your patients, they're your families. And be engaged with them, be present, have a meaningful interaction. Don't do it because we said so. Do it because these are your people. This is your medical family now. Be attentive, be calm, assured, yet not meek. It's the presence again. It's your presence. Practice again. This is what I tell some of my very kind, mellow, soft physicians. Practice being big with a mirror. Next. Now, you've entered a room, you've engaged, you've made that eye contact. You're going to be known by your work ethics now. These are very important. This is medical standard time, not Desi standard time. Timeliness is virtue. Set alerts on alerts. My favorite gift I will give you today is in your phone. There's a calendar app. Your every effort, everything that is meaningful should have an alarm on it. Set alerts, check those alerts. Time management is key. Divide your day into times. Times by lunch, times by prayer, times by your clinic, whatever works for you. Please divide your day and you will conquer. Your reputations are earned. And then you may keep them for a long time. They can be mended, but takes years. Tardy is irresponsible. So please be responsible. Please be loved. Please be valued by being timely. Next. Now, this is a trait I think we sometimes grow up with, possibly, that you don't know everything, my dear friends. You are seeds that are gathering light and water. Gather that light and water. Your data, your inquiries are what will make you grow. I call my residents my why machines. They keep me young. They keep asking me why. Ask why. Your asking should be like artificial intelligence. Once you learn it, now let's not be like hey from Moana who keeps asking, hey. No, once you learn, accumulate and learn it. Repeat it at night, reflect. Manage your stress. This is, if I can give you, my second pearl is going to be, take care of yourself. Now that you've arrived, take care of yourself. Put on your mask, as they say in the airplanes. You have to put on your mask to be able to put your mask on others. If you are sensing issues, talk to the counselor on hand. Talk to a friend. Do not internalize. Do not postpone fixing it for a later day. Now that you have a plan on exercising, prayer, meditation, eating healthy, reign, take care, be that part of that machinery in the wards, but know who runs the wards. Now, this is very important from Pakistan to here to any other country. My nurse friends, they are your building blocks of the floor, of the wards, of the hospital. Respect them, learn from them. They run the show. They have years of experience, most of the senior ones. Now, it's okay. This is a story I want to share with you of a stressful doctor, stressed, we'll call him. He was doing his notes one night and he asked one of the nurses, my shoulders are tight. Hey, could you massage my shoulders? Not a good idea. Not a good idea. Let's keep physical contact a bare minimum with your colleagues. Patients should be on the medical basis. Bring them candy, bring them cookies, beautiful gestures to make friends, to make up for a mistake sometimes. But be very careful about physical contact, physical advancements, verbal advancements as well. Next slide. Absolute no-nos. Now, when we arrive, this has happened to a loved one on the streets in Boston looking for the hospital. You see an older lady. She's not an auntie. Auntie, where is Longwood Lane? No. Excuse me. In some states, you will see a coastal difference. West Coast versus East Coast versus the South. In the South, I trained West Virginia. They call you hun, babykins, pumpkin. All of those are beloved terms for your doctor. And it is okay. You will gather the strength. You will gather your entourage of words. But till that time, know that there are coastal differences. In the West Coast, You may be addressed by your first name only. They may not call you Miss, Mrs., Mr. because they don't know your pronouns. Your pronouns, he, him, she, her, they, them. That's very important. Respect it, learn it. If you Google something today at the end, please Google that. The gender identification, respect your families. It is not for you to judge, it is for you to respect. Now, seeing a pregnant colleague, beautiful thing to have, but a story of my good buddy, we'll call him John P. John P ran into his colleague in the hallway and says to her, congratulations, baby in the belly. She, stern friend of mine, says, I'm not pregnant. He says, get out of here. You're pulling my leg. No, she wasn't pregnant. So let's not be a wise guy, wise girl. No need to assume. Could just be a buffet meal this female just had. And by no means touch the belly of a pregnant person. If you're on a Zoom call, this is important, happened to a loved one of mine. You're on a Zoom call. You are addressing people for a work issue. You see a woman brings in or a man brings in their child. No need to engage with the child. No need to comment on the child. They may take that as a microaggression, that you are belittling them for bringing their child. So this new, advanced, this learned culture we live in, be very aware. As the young people tell me, be woke. Learn the woke things. A crying coworker can sometimes be a line that you have to walk. Be kind, be present. But I have learned from a good colleague of mine to ask permission. Can I hold your hand? Do you want a hug in front of one or two people? You don't want to be known as the serial hugger. One of our cardiothoracic surgeons actually went to HR because she was having a rough day and another anesthesia colleague went and hugged her. So we don't want to be known as the serial killer. I mean, the serial hugger. It can kill your career though. Next slide. Work ethics is something that should not need mention here, but this is something that happened to us. We had a second-year resident who, after dropping his little ones, would try to do notes from the car. This is not just wrong, it is grounds for getting terminated. So be smart, don't take shortcuts. It's okay to say I was late, to be human sometimes, but don't lie to make up. Now, don't share info in the hallways again is another one. This is another story of one of my, we'll call him Dr. Jim. He yelled to his family in the hallway, your results are back. Your AIDS results are back. Your HIV results are back. Good, congratulations. No need for that. Again, you will be taught this. It'll be ingrained, but learn some basics. When in doubt, don't say it. Office supplies are office supplies. We've had a resident put on probation. He would take printer paper home. He would take printing supplies home. He would sit and use the phone for international calls. Don't be goofy. Don't be silly like that. Next slide. Now that we've said all this, remember, you have very few, but you have rights. You have the right for respect. You have the right for getting a reasonable break. You have a right to pray if that is what you will do. Again, I bring this to you again and again. Your stance with your clothing, if you will wear your turban, your hat, your yarmulke, your Pakistani shalwar kameez is your right. But please be sure that is what you want. A break for prayer should not be an hour. Do not do your nafali ibadat, 17 anfal at that time. Remember, work is your priority at that time. I wish you all the very best. We are here to answer any further questions. Thank you.
Thank you, Dr. Nasser. Let's see. So Dr. Malik, you want to take over from here for the next section?
Yes, sure. And thank you, Mana. Thank you so much. Do any one of the participants have any questions?
Do you want to take the questions now or we take them towards the end? How do you want to do it?
Well, we can take it questions from Mana now, so it's all relevant and in their head. So we can
Okay. So if any participants have any questions, please post them in the Q&A section. We have one. Should we report doctor for verbal sexual harassment?
Absolutely. Absolutely. You would report them to your, I would say, verbal sexual, that is sexual harassment. We don't even have to define it as verbal. That'll be HR's job. Absolutely. No question.
Yeah, I think that's all I had. So, and then what if we do not have proof?
Does not matter. As soon as it happens, you have to go talk to somebody. This is your right. And that is HR's job to give you a safe environment. Talk to your superior, your chief resident, if that's the offender. Again, first HR, and bring in your chiefs and everybody else that's involved.
Yeah. Okay. Any other questions related to the first section of the presentation? I don't see any at this point. Okay, so I guess we can move on, and then if questions come up, we'll take
One
them.
thing, I don't want to miss this opportunity for that friend that asked. God forbid any of these things happen to you, or you are involved. Somebody accuses you. Very important, because this is the culture right now. If somebody accuses you, or you're the accused or the accusee, details, write them down. Take a memo book, put it on your phone, minute by minute, as they're fresh, as Malik said. Put details in your memory somewhere, time by time, where, when, why, who was there, around time. Please, that is very important. As soon as it happens, try to recall.
And this is an important point. If you have complaints, it has to be written. If you tell someone and whatever the conversation was is still in the air. So a thorough complaint or anything is always online. And when I go to the inpatient section or the clinic sections, there are different websites in the hospital system that you can complain, or you can write SOFIs, or you can write safe reports, meaning something missed somebody, a nurse missed, a doctor missed, and it was patient care. They have a full reporting system that you have to log in and chart that, because everything is documentation. And just adding, when you opt to wear shalwar-kameez or yarmulke or turban, be professional, because with that shalwar-kameez, you should wear a white coat or a stetho or a ID, because that's your uniform. That will distinguish you from other staff that you're a physician. So last minute,
we have some more questions, I think.
Okay,
Can we give PD or others gift out of respect in initial days?
To your program director, a gift, it should not be over $50, and absolutely you can, yes. Now, again, the gift should be lingerie. Gift should be appropriate. Let's just the gift.
Right.
Appropriate gift, culture gifts, and in holidays, like everybody, each staff gives each other, like especially in Christmas or New Year.
Yeah, I think the key there is it shouldn't be very expensive, appropriate, and then, as Dr. Nasir said, you have to keep it under $50. Usually $25-$30, you get a nice gift basket or chocolate box, and that should be okay.
So Naman is a PD, so he's telling you what he needs. All right, I think it's 10:29, so we'll start our section. Amana, do you want to say something? Or?
No, sir, thank you. I think I forgot to introduce myself. I'm Amina Nasir, one of the pediatric gastroenterologists, class of 1998, Aga Khan. Now it's St. Louis Children's Mercy. Thank you. Have a great day.
Thank you, Mana. Thank you so much. It's so nice of you to give us this and share all the experiences. So I'll go to the inpatient bootcamp section, and I will introduce myself. I'm Mohammed Malik. I'm one of the director of hospital medicine, and now I'm a senior hospitalist at Mercy and SSM Health. I'm from Sindh Medical College, and I practice medicine at St. Louis University. And the facts are like today, Noman, Hasina, Amana, and me, we all are from Missouri. So I'll start with, if you, Noman, can you put my slides on? The inpatient world. Okay. So the inpatient world is your hospital work. Anyone who's in internal medicine or family medicine, or even some other specialties like neurology, they will go into internal medicine world. And internal medicine world means the hospital world. It starts very early. There's some attendings who start seeing patients at 7 o'clock. If they start at 7 o'clock, then you have to be in the hospital at 5 to see your own patients first. and write the notes and stuff. Hospital is divided in different floors. There are med tele floors, surge tele floors, ICU, step downs. So there are different floors which cater different complexity of patients. And that thing is important. Sometimes most of the hospitals are geographic rounding, meaning you're in one section, you're in ICU, or you're in a cardiac tele, or sometimes you have a mix of patients from ICU to med surg, or so there's a difference of complexity of the patients. Whatever the list you get as an intern, your upper level will give you 2, 3 patients that you have to know this patient by heart. And when I say by heart, it means that you have to know their history, which is, and you guys have done it. You guys have passed all the exams. You have all the tons of knowledge and information. Now you just have to learn the American culture. And now you have to learn the American way of doing practice medicine, which is a little different from the England or Pakistan. So the hospital floors, HMP is the same. The format is the same. Progress notes, which is like a follow-up note, is a SOAP note. It's more like a subjective, objective assessment and plan. Then comes the discharge summary. These are the few notes you have to do in the hospital on patients. The rounding starts if the patient has been assigned to you. The night team will check out to you that how many admissions they have, how many floor calls they have. So what that means is that when you come 5 or 6 in the morning, there's a huddle between the nocturnist, the night team, and the morning team with your chief and attending sometime. And the night team will present you that these 4 admissions they have did and what are the floor calls, like admitted patients have problems over the night. Right there and then, the chief or the attending or the upper level will give you 2, 3 patients that you have to go on. When you go to these patients' rooms, you know the ethics, as Amana said, but there are different EMRs, electronic medical records. It could be Cerner, it could be Epic, and they're going to train you on those EMRs. These EMRs make your life very easy because most of the HMPs, progress notes, or discharge notes are pre-populated. What that pre-populated means, it will take all the data and put it in your history. And the best part is that they all have an app. So you have to download an app for Epic or Cerner or whatever EMR you're using on your phone, and your phone is like everything you need to present or to know about this patient. HMP has the same format, and the best part in the EMRs, they're dot phrases. So the first day you go in, you have to sit with the upper level, get their HMP progress note and discharge format. They will give you the format. These are some coding formats, and you have to copy and paste, make changes as you go on that to bring more information. But then you can save those formats on your name, like if your name is Muhammad Malik, MMHP. And the next time when you open a patient's chart and you want to do an HMP, all you have to do is .MMHP, and it will bring you all the information, the labs, what is the past medical history, what is the medication list. Now, what you have to do is write what's the chief complaint, what is the history presenting illness, and what are the exams, and what is your assessment plan. So it makes the data part, which you have to gather, it brings everything to your format, and that's the best part of the EMR. And same way with the rounds, the SOAP notes, the follow progress notes, it has the same thing. So the day when you go, you have to ask them, like, what are the dot phrases for different notes? And even these dot phrases are easy to do. Like if I have a COVID patient or a CHF patient or a COPD patient, I have a dot phrase of .MMCOPD, and it will bring me like what we do and how do we manage COPD patients. And then you can tweak that on that patient. Patient is a smoker or not, patient is on an inhaler or not, patient is on steroids or not. So it's kind of like a checklist, you don't miss it. And you have to make those dot phrases for different treatment and diagnosis. It will be very helpful to you. And when you go in there, you will see how to create all those dot phrase and dot format. But this will make you very quick. Dot phrase, dot thing, and everything pre-populates, and you're done with your HMPs or progress now. Now comes the presentation. So the templates is always the same for HMP and progress note. I would advise you to, for first few days, do see the progress note or do see the HMP and then present to your attending or your upper level, because you want to be very accurate. And don't worry about your accent or your language. because everyone has different accents. Even like if you go from South to East Coast to North Coast, they have different accents. I remember I lived in New York and I came to Memphis, Tennessee, and that's where I got trained at University of Tennessee. And the first day I went to clinic, and there was a guy who said, like, I have Charlie horse in my leg. And I totally did not get him, like, what was he saying? So it was this thick accent. So don't worry about your accent. All you have to do is say the full words and go very slow. If you go very slow and you say full words, the other person will understand you, and then they can comprehend like what you're saying. So same way in the presentation, when you present to a attending or your upper level, try to slow down, try to say all words, and first few days have a note in your hand so you're literally presenting. Yes, go ahead, Amana. Do you have any question?
Add on, knowing those nuances, Charlie horses. I had a good buddy of mine. He took a history from a patient, said, I was driving down 64 and my car turned turtle. The doctor, my buddy, he called a psych consult thinking this guy was a Cocoa Puff. But the poor patient, the car turned turtle. The car went upside down. So before you condemn somebody to being a psychiatric patient, know the slangs. Your nurses will help you. That's it. Thank you.
Yeah. So, and this is how it is. Like if you talk to a patient in New York, they have a good Eastern accent, and you have to pick up, and you'll pick it in a few days. I can promise you. Southern accents are a little difficult because they have more slang and stuff, but you will still pick up. If you don't understand, tell them to, can you repeat yourself? Can you go slow, and can you break it up? I don't understand the part. So they are very nice, and they will tell you like what they're trying to say. So do present slowly with each words. If you don't know, if you're in doubt, ask your upper level and present for, I would say, first 3 days, present with seeing it, looking at the paper. But from there on, the expectation is that you know your patients and present it as a story. Like, this is a 36-year-old with a history of COPD and smoking who comes in with a shortness of breath. So it's like you're telling a story to what's happening, what are your findings, what are the labs, and keep it simple. Don't go away. It's a format that you have to follow, and as a physician at an upper level, should be built in your head that what format you're going to follow. Don't go to the diagnosis first. If there is a question in the middle by upper level, try to answer that and go back to your format again. And Mana, do you have any question?
No, sir.
All right. Okay. So the main part of all the residency, the inpatient or outpatient, is read, and read. You see cases, you have to read it. Most of the hospitals provide you up to date, and that's up to date is like a current medical diagnosis, which we used to read the books, but now up to date has all the diagnosis. It gives you with all the different studies. So it's just not text, but there's studies as well. Make sure that, this is going to be tough. You have to get 5 in the morning, you have to round on the patients, you have to write the notes, then you have to do admissions. And then by the time you're going home, it's a little like 6 and 7, then you have to catch up on your Z's and sleep as well. But make sure you read an article or two for sure on night. The Up to Date has an app as well. Download that app. Hippocrates is another EMR, is another more like Up to Date, but it's very comprehensive. It's very short because Up to Date is a big, huge articles. I would say for rounding, Hippocrates Health as well. It will tell you what tests to do, what examinations you have to do, what will be the findings, and what will be the assessment plan and the treatment plan. It's very short and quick as compared to Up to Date, but don't give up on your reads. This 3 years or 4 years of your residency, you have to read every day. Make Up to Date your friend, and it gives you CME points as well. And when you present a case and you mention a study, that there's an Up to Date study, which is a double-blind random study, that gives very weightage that you're very academic, that you have studied and you're talking on data, just not in the air. Going back to the hospitalist and EMR, the EMR is your best friend. Know your electronic medical records really well. There are order sets. When you do admissions, there are order sets for COPD, CHF, and everything. And it's like a checklist. You don't miss anything. If you start putting all the orders for a CHF and COPD, it will take a long time. The order set, you pull up order set, you just select whatever you want to do with this, because if somebody has diabetes, you cannot do more steroids. So tweak a little bit, but it's a checklist as well, because you're not going to miss anything. It's going to remind you, do you want this or not? So order sets are important. Dot phrases are important, especially for progress note, HMPs. And then I will make dot phrase for your diagnosis as well. Some case presentation, hospital expectations. I'm pretty sure Naman will give you on the scoring and like how does the score goes and how does other things work. But your evaluation is all dependent on like how you're presenting with all the patients, number one. Number two, are you reading or not? They will give you assignments to present. They will say, okay, you saw this case, and if the diagnosis is a stroke or CVA, why don't you present stroke? And that's where you have to make presentation from up to date and present to the whole class. So that's the important part, that you're reading for sure. When you go into the hospital world and inpatient, you have to have a spatial relationship with the consultants. Try to call them and learn from them. They will teach you as well. What is new guidelines? What are the basics? And as just not your attending or the upper level, the consultant teaches you, like the nephrologist, the cardiologist, the pulmonologist, they all teach you really well in an academic setting. So be friends with them and be respectful to them. When you consult them, just don't tell them there's a consult in room 215. Try to call them and tell them, like, this is a 36-year-old who comes with this is his past medical history, and I'm consulting you for this reason. And if you have any queries or questions, ask them, what you would do for this COPD, or what you would do for this scenario. And they will tell you, like, what, this is a special scenario, I'm going to do this because this is the recent studies, or this is the recent guidelines. And the third part is, so you're attending, your team, your specialist, your consultants. The third ones are the nurses. The nurses are your eyes and ears. Respect is number one. They're very experienced nurses. So they can teach you and tell you, like, when is patient going south. So you have to respect them, be respectful to them, make relations. When you go rounding, the first thing you do is a MD-RN round, meaning you go to the RN and tell them what's happening with this patient. How was his night? Did he have any fall? Did he have any changes in the night? And she will tell you everything. Because they are there 24/7. They are your eyes and ears. So you have to talk to your eyes and ears, like what happened to the patient, and they can tell you the minor details. Did the patient had a BM? Did the patient voided? The patient had chest pain, fall? How's his breathing? So everything A to Z. Do talk to your nurses before going to the room, and you'll be well informed. And then patients are very impressed that because each small and every details about them. So they think you're a good team, because whatever happened to me overnight or in the morning, he knows about it. So he's my good doc, that he knows everything about everything what I did overnight. So consultant relations with nurses, and the third thing is your attending, of course. The nurses will give you floor calls, even if you've done around with them. Take it seriously. Now they don't call you or page you. There's a haiku service in Epic. There's another service in Cerner. So they kind of like more text you, like what's going on with the patient, and you have to answer them in a timely fashion. There'll be nurses, there are some new nurses. We had some shortage of nurses, and then we got into new nurses, a batch, and they are a little anxious. They will question you. They will send you 7 texts or 8 texts on a patient in 1 hour. Be patient, answer them in a timely fashion, because if you don't answer them, they will call you upper level. So that communication is very important as well. Besides admissions, rounding on the patients, when you're on call, there will be 2 things which will happen. One is a rapid response or a code. Rapid response as a code is when patient is going south. So patient is still stable, but has a new event, a stroke or a chest pain or an AFib. And then you have to go into that situation, even if it's not your patient, and then you have to tackle it. That's where the first thing comes in, which is the ACLS, BLS. And I know like you guys are probably doing those ACLS, BLS now, because no programs will let you start before this ACLS and BLS. But try to go there, jump into conditions, because you will learn. Even standing there and a ICU or critical care physician is running that code, you will learn from it, like how's it going. Third thing, evaluation will be covered by Naman, but there's a ACGME milestones, which are very important. These milestones will be in your evaluation, that how good is the training going, and are you achieving your milestones or not. And then comes the rotation evaluation in service exam. I think in service exams and the step 3, if you guys have not done it, that's the most important part. All the programs that look for like how we have trained him and how is he stable to do it. And if he's passed step 3, then the next big, huge question is the board exams. And every program is assessed that like if their residents and their training is good, have they passed their boards on first attempt, and they did it safely or not. Hasina has a question, so
Yeah.
We'll take some questions and I'll add a few more things. Okay, go ahead. Naman, what questions do we have?
Let's see if Dr. Hasina Mazur has her hand up. So if she wants to ask, and then I'll check the.
Okay,
Q&A.
yes, Hasina, go ahead.
You're on mute.
Yes, Hasina.
Yeah, sorry. Yes. For the code part, usually the residents from first year to third year, they will be assigned. So suppose I am the first year, I'll be assigned that I'm on the code group. And once the code runs, you're in the bathroom, you're in the canteen, eating, you have to run to participate. And I'm saying that because I used to have an intern who always comes late in the code because he said, oh, I was having my lunch. So we have to kind of guide him that how important it is if the code runs and you are assigned for that specifically. It's a good idea to go whenever, as Dr. Malik said, but at the same time, if you're assigned, it's your duty. This month you are in the code group. You have to make sure you don't miss it. Whenever it is runs or rings the bell, you have to rush. Even you have to run and go and make sure you take your part on the code group. Thank you.
And that's the important part. So when you're responsible for a code, there is no one else going. You're in that team. And if you're missing, then they will mark you as that he's not showing up on time. So it's a discipline that you have to follow. And this is why inpatient is a little difficult as compared to outpatient world, because it's just 8 to 5 here, that there are no set timings. If the attending is starting his rounds at 7 a.m., you have to be at 5 to see your patients, look at the list, be in that huddle from the night team, see your patients first, and then go to huddle sometime, because you don't have time. So a day in inpatient world could be longer, and that's why you need more discipline. You have to catch up on your sleep. You have to eat whenever you can, and then, as Amana said, the hygiene. You can wear scrubs, but with scrubs you have to have a white coat and an ID and a stetho. And if it's in pediatric world, at least scrub or ID badge. You have to have a hygienic condition, take bath, and which makes you refreshes you every day. Even if you want to take 2 baths a day, you can take it. It refreshes you. Coffee is your big friend. I know I was a tea drinker in Pakistan, but when I came in, I became a coffee drinker, and you need that morning start and a kick. So that kind of help you, give you energy. Don't rely on the energy drinks. I see people like drinking tons energy drinks, and it makes you more jittery and anxious. So balance your coffee and caffeine intake or energy drinks. Get into your sleep. Your sleep is important. Whenever you get time, sleep. And the read is the most important part. Whatever you see those cases, read from a authenticated, like up to date, which is you can't quote Wikipedia or you can't quote Google search, because that's not academic, that's not database. So what is evidence and database? That's what you have to study and read, which is up to date, Hippocrates or John Hopkins Antibiotics Guide, and then quote that. All right.
So there's a question: do they need to buy their own up-to-date, or hospital will provide it?
Most of the residency programs, they have their own up-to-date subscription. The hospital has their up-to-date subscription. and you have to go every a month or two to keep that alive. There will be app as well, and as you go, they will give you that subscription.
Okay.
They're also going to another system called Dynamed. So just your chief resident, your program director will tell you your source, Dynamed or UpToDate or some other one. So don't buy it.
And you don't have to buy it. And even if you want to buy something extra like a John Hopkins antibiotics guide or Hippocrates, there's a CME money for each resident that you can buy a different subscription.
Okay, yeah, those, let's see, there's one more question. What would you recommend instead of coffee for someone who gets palpitations with coffee? Anna.
I was like that before, and because I switched from tea to coffee, and if I don't drink coffee now, I get palpitations. So I promise you will get used to it. And once you're lessen your Z's and you're hardworking and your days just going through, the coffee will help you. The other part is that some people have tried the non-caffeinated one, and it kind of gives you that hot, warm drink sensation. So it wakes you up. So whatever wakes you up. But I will still say not the energy drinks.
Mama Doc
Yeah.
say chai, matcha, 50 jumping jacks will wake you up.
Yeah, exercise is important. Like exercise, sleep, diet is very important because this is a 3 year of training. And ICU, you will see the ICU settings, you will see when you go into the nights, the whole circadian rhythm changes. So discipline is a very important thing. You can watch Netflix in the night and try to go in the morning with 4 hours of sleep. You will be cloudy. So you can do this after the residency, but I would still say this 3 years, try to learn and read as much as you can. And if you want to pass with good numbers, the discipline is the main thing. The time management, sleep whenever you can, eat whenever you can. You don't say like, it's my lunchtime, I'm going to go for lunch now, and thank you so much. No, if it's work, you have to do work and catch up with the lunch whenever you can, early or late.
I think that's all the questions I had.
All right, great.
Okay.
So I think Hasina is next.
So I have her slides up. So Dr. Hasina Mazhar, if you want to start, you want to introduce yourself, and then I have your slides. I'll advance them.
Yeah, can you see me? I don't see myself.
Yes. Yes.
Okay. All right. Okay. So Assalamu alaikum and good morning. I'm Dr. Hasina Mazhar. I'm from Dow Medical College, currently practicing outpatient SSM Health, St. Charles, Missouri. So we'll talk about outpatient world, how it's going to be during residency and afterlife. And again, congratulations all who match. So outpatient is all the services during your residency time when you are not in the hospital. It can be primary care clinics like internal medicine and family medicine. And it can be urgent care, specialty clinics, community health clinics, where you're going to take care of your patients. Okay, I'm going to be looking around because I have a bigger screen open, so I have to have my slides there too. So outpatient, as mentioned, some of my colleagues, that it is a part of your residency, a smaller part. So in a hospital is more like fast pace. You have to be early in the morning, but outpatient going to be your recovery time. It's going to be a little stronger. You're going to looking forward like, oh my God, today is my clinic. I'm going to be a little ease on my day. But it will help you to build your relationship with your patient. Because when the patient in the hospital, they are worried about, I have a COPD or my heart is failing. They are not telling you a lot of detail in terms of how their general health is. But when you see those patients in your clinic, you have more time to talk to them. They will see you. And it's like we have a new friend. You meet every time, you know more about them, and then you can take care of them better. You're going to be rotate through a primary clinic, which is internal medicine or a family medicine, but especially clinics like neurology, endocrine, and others. Kind of similar. All right. So when you're going to assign a clinic, suppose today is your clinic day starting 1 p.m. So you go to the clinic they told you. There's going to be nurse or nurse in charge who are going to tell you, okay, room number 1 and 2 is going to be your rooms, and the doctor's rooms is so and so. You go there, you're going to have other interns and residents, and you're going to be assigned attending who are going to be the same senior doc with you, who are going to guide you and mentor you and tell you how it's going to be. So before you go into rooms, just remember you're going to be assigned, for example, I will take it slow, like maybe 4 patients from the beginning, and you're going to tell, hey, you have a half hour for each patient. So you have to organize your time, make sure you go there, take your all information, take all the answers from questions from the patient, explain everything, and come out with a plan. So in order to best help, you have to make sure you take charge of that exam room. For example, when I go into the room, I introduce myself. Hi, I'm Dr. Ali. So you're new for me, or okay, you are here for your follow-up. And the patient will come to you and ask you that hey, doc, I have this question. They will bring a list for question to you, or they're going to say, oh, I have a rash. I want you to look into that. Or they're going to say, oh, I have a bad headache, or XYZ. You say, you can smile and just tell them, okay, let me open your chart. Let's review the basics, and then I'll come back to your question and I'll take care of you. The reason is if you start from the basics and get all the information from the patient and then guide the patient, you will able to time yourself better. But if you go in the reverse, so go directly with the patient has questions, you might able to miss some of the stuff. Suppose the blood pressure was high, you might not able to see that. There was a medication you were not sure about before you leaving the room. So make sure you review everything. Okay, let's see your blood pressure, let's see your medications. And if you have a time to review the chart a little bit ahead, maybe 5-10 minutes before, you know exactly who's coming, what is the reason, and then you can prepare yourself. For example, until now, I have like papers, I keep it with myself because in the clinic, I have like 20 plus patients every day. So I write their name and their reason they're coming, and then just take a small notes while you talk to the patient. So suppose when you leave, you have something in your heart and you don't miss anything. And you summarize the patient. Once you get all the information, you ask the patient, hey, what you so-and-so missed, what question do you have? And when they ask you a question, you can explain them. For the suppose the patient says, oh, my neighbor says I can take this multivitamin. You can explain then, okay, among all 3, you can take one. Oh, I have a rash. You can explain them how to take care of the rash. Oh, I have a headache. Let me send you some medication. Doc, I'm not able to sleep well. Okay, let's see which medication you are on. Okay, you are already on this sleep medication. Let me make it a little stronger for you, and let's try how you do, and I'll see you back in a few months. When you summarize everything, tell the patient that, okay, let me talk to my attending, then I'll come back and let you know if any other changes before you leave. And then you go and talk to your attending. When you go and talk to your attending, your senior doc expects you to come with a plan. Suppose I'm the intern, I go to see a patient and the blood pressure is high. I take all the history, I come out and I'm talking to my attending. The attending asks me do you have any plans? What are you going to do about it? So then you have to look into the list of the medication patient on. Do you want to increase the medication? You want to add a medication, and why? Rule of thumb is whenever you want to change the medication or start a medication, you look into the kidney function to make sure it's not affecting the kidney function. And of course, the pulse or the heart rate, because some medication affect that too. Next. Difficult scenarios. So there's always a chance you might encounter difficult scenarios. It can be on the floor and it can be in the clinic. So suppose you go and in the clinic, you open the door, you introduce, you smile, and want to start your visit, and patient is upset. Now, I'm your patient. I'm upset with you because you didn't give me a medication, or I'm upset with the front desk because they did not check me in. There's a scenario can be like a family is there and they're upset because they're not on the same page, or they're upset because they didn't like anything the way you're taking care of some of those scenarios. And there's going to be, for example, I had a patient who came in with weight changes a few weeks ago, not eating well, and we did a CT and we end up finding some mass on it. So if it's a bad news, you don't tell a nurse to go and call patient, let them know there's a mass and it looks like a cancer. You have to call your patient yourself and let them know, hey, we did some testing on you, So we were expecting to see why so-and-so is going on. Do you have any information? Did you receive any call? The patient says, no, doc, did you find anything? And then you start telling them little by little with some pauses so they can understand it. And then explain them what's going to be next step from there, how you're going to proceed further, who they need to see, and all that kind of scenario. Patient who are upset with you or family scenario, again, you have to control the environment. You get, for example, I'm upset. You didn't give me medication for your sleep. I want X, Y, and Z medication. You said, hey, I understand you're upset. Let me check what happened. Go back to the chart, because of course you're not going to remember all the patient by heart. It's keep changing, but you go check and see why you didn't do it and explain the patient it is not medically required, or it is contraindicated because of X, Y, Z, whatever the reasons are. Try to work with your patient, try to work with your family, try to help them best, because the more we're going to talk to them and the reason we explain them, sometimes face-to-face resolve most of the conflicts and help them understand better compared to when they receive a message that doctor refused it or did not recommend it. Rarely it can happen. You might get a personal comment also, as some of my colleagues mentioned about the accent. Oh, I don't understand, you have a thick accent. Just remember, this is not our first language. Our first language is different, but we are able to talk so fluent. But they're always going to be, depending upon which area you're getting your residency, there are going to be areas where they pronounce differently the way we are. But the idea is to learn how they pronounce, try to correct yourself, but keep calm on those scenarios, take control on those scenarios, then do not get offended immediately and try to resolve that and smile and move on. Or outpatient clinic, what I learned is that there's folks comes who are elderly. Many of them has hearing aids. I have patients who have hearing aids. Many times they do not wear it when they come. And when they come by themselves, it's very important we talk to them very slow. Sometimes you have to repeat it. And in some of the scenarios, you have to give written instruction to your patient, like number 1, your blood pressure medication has been increased, pick up from the pharmacy. Number 2, go to first floor, get your X-ray done. Number 3, call your cardiologist, and so on and so forth. So giving those small instructions helps some of the geriatric patients who may not able to understand fully. Next.
We have Dr. Malik's hand up. Do you want to say something?
So I just want to add, like in the hospital setting now, because there are more metrics in the hospital. Metrics means the quality measures. Metric means because the patient care is supreme. Your training or your physician you're attending, they all care about the patient care. There should be no issues with patient care. And patient care is tied up to patient experience. Like how is the patient experience in the hospital or in the clinic? So there's a thing called HCAP scores in the hospital settings, which also goes in the clinic settings, which is, did your doctor listen to you? So it's very important you listen to them. And they get a survey after the visit in the clinic or in the hospital that did your doctor listen to you? Did your doctor explain to you like what was he doing? And then the third, they say, did the doctor tell you the plan and was respectful? So respectful, listening, and explanation. Those are the 3 parts that you have to work on. And they literally get a score and a feedback card in the mail. Then they rate you, and the hospital or the program will give you the HCAP patient care experience scores to you. Thank you.
Yes, so that's right. That's why when you enter in the room, you introduce yourself and you try to control the environment in a way that you go through the basics first. But at the same time, once you're done with all your with exam and asking patient questions, then you ask the patient, what question do you have for me? And answer all those questions. And then explain, summarize at the end what the plan is. As I mentioned, you like changing your blood pressure medication, sending you this labs and all that, and then explain all that in written instructions. So make sure we cover the area that patient being heard, and you explain everything, and we are on the same page. There can be scenarios where patient and you might not be on the same page, but at the end you have to think only one thing: what is best for the patient. Do not harm is one of the bigger things. So a patient asking you some medication or a recommendation which you feel is not safe for the patient, you kind of explain them why you're not going to do it, but summarize at the end. And that's how you take it from there. Next. So, oh yeah, tricky scenarios. Okay, we are already here. So tricky scenarios happen. This is after residency also. For example, you enter in a room and it's the wrong patient. You open a chart, you open more than one chart in your computer when you seeing patients, suppose in the clinics, and you open a wrong chart talking to a person and didn't realize it and give a wrong discharge summary. I had a colleague of mine, the patient got upset because the discharge summary given by the nurse in the clinic was, because suppose if I click a discharge summary and the next doctor's discharge summary, it might come to the same printer. And if the nurse grabs the summary and give it to the patient and it's not the same patient, and they go home and they have information and data of someone else. So it's kind of a legal thing also. So make sure the summary goes to the right patient. And suppose if I end up prescribing the wrong medication or vaccine. For example, there was a scenario in which a patient came to receive a vaccine, pneumonia vaccine, with a son. And patient was giving pneumonia vaccine a few years ago and supposed to receive B this time. The nurse was giving instruction to give vaccine B. She went and she grabbed vaccine A, give it to the patient. But before the patient leaves and she realized and comes to the doctor like, oh my God, I gave the medication patient will receive. So what you're supposed to do? In all those scenarios, the rule of thumb is simple. You understand there's a mistake has been made. And number two is we need to fix it. Fix it by not covering it. The best thing is to talk to the patient, go to the scenario. And if you're a resident, of course, you need to talk to your attending or the senior resident with you. How are we going to approach from there? So learn what are the parameters, how they can guide you, how they've taken care. For outpatient world, like currently for me, if that's the scenario happen, what I do generally, I'll talk to my patient, hey, this has happened. You were giving the wrong vaccine. And if that's the scenario, tell the patient or the family what to expect. So if the vaccine is given accidentally, the same one, you expecting allergy reaction? No, you're not expecting anything, but apologize. Okay, let's monitor you. Let's give you a call in a week and see everything is how it's going to be, and then take it from there. And it happened the same thing. If you're in the wrong chart, one time, what happened is that we run out of something happened, internet shut down or something, and then some computers are working, some was not working. So exam room, some of the computers are not working. So the idea was, okay, go back to your room, see the chart and go and see the patient. So what happened with a colleague of mine, open a different chart with a different patient and dictate and realize it is not the same patient. But what they do is then fix the data, make sure they didn't put any wrong medication on that. But generally, if you do something or you come to cross some scenarios, the idea is to admit it and fix it and talk to the patient or the family member and take care of the scenario and do not hide. Next. Okay, so when you're in the clinic, you're going to see different patients, of course, with different scenarios. Patient coming with psych problems, mood problems, depression, anxiety, schizophrenia, bipolar, and others. Remember, the rule of thumb in those scenarios is going to be make sure most of them are calm and most of them are controlled, but the way you're going to interact with the patient is make sure the patient is sitting in the exam room in the inner side and you're sitting on the door side. That is something I've been told when I was doing my observership with the attending and dealing a lot of patients. And I always remember, he told me, okay, you need to sit on this side because if so-and-so scenario happens, you need to know how to take care of yourself and how to take care of your patient and the scenario. That's one point. The second point is when you go and see a patient in the exam rooms, the patient can become with suicidal ideation For example, yeah, I feel I'm better off my life, then that comes the counseling. But the patient comes with a plan. Okay, I'm going to leave this clinic and I'm going to go on a highway. I'm going to stand in the middle. That situation can be tricky. That patient should not leave the clinic. You cannot say, hey, you need to go ER and say, doctor, patient says, yes, I'm going to the ER. No. In this scenario, you explain the patient is you are harm to yourself. Let me help you. We need to coordinate with the ER, get someone, EMS there, and take the patient to the ER. So make sure patient is not harming self or others in this scenarios. For others, the patient is saying that I'm going to go and I'm going to my wife did this and so my neighbor did this, I'm going to do this to them. There's a certain protocol you have to follow. You make sure the patient there, you go and talk to your attending and find out how you're going to approach the scenario to inform or taking care of the scenario, and make sure you take your responsibility and take care of that scenario. Patient can come in depression and start crying in front of you. You have to understand that depression, anxiety is, I see a lot in our patient world. It's like a lot. So have to have the empathy. Empathy means you understand they are human beings and what they're experiencing. And somebody comes in front of you and crying, it's a real deal. You have to take care of them. You have to explain them how you understand what they're going through and how you're going to take care of them. Take care of them with medication, with a counselor, short follow-ups, coming back, seeing in a few weeks, and then you're there for them. And some of this challenge scenarios, suppose if you're not sure how exactly to approach, excuse yourself for a minute and ask the patient, I'll be back in a minute. And then go and talk to your attending, make sure someone is supervising the patient, and get input to your attending and senior resident, and come back and take care of some of those scenarios. Next.
Can I just add one comment because
Yes.
to what you mentioned? So I think what's important, which you were mentioning about the homicidal ideation, if someone wants to harm someone, there's a Tarasov law. So you guys should read up on it, and it's very important. And the law says you have a duty to protect and the duty to warn, and both things have to happen. So the way you protect is, as Dr. Asina was mentioning, you will admit the patient, so keep them so they are not outside, they cannot harm someone else. And duty to warn is then you have to warn that person who the patient was going to harm. So either you try to reach out to them or you contact police and let police know to reach out to them. The other thing is you never discharge a patient on your own. You always run it past your attending. So you're covering the night shift and the patient wants to leave AMA, or seems like patient is fine and you feel like patient can go, you are still a trainee. So you have to talk to your attending, because if anything, if there's a bad outcome, patient's discharged, your attending would definitely, if there's a lawsuit, they would say you never discuss the case with them. So you always want to protect yourself, always get the blessing and then do these things, because we do see it commonly. Sometimes residents are like they've done first year, then second year, they feel like, yeah, I know patient is fine, I can do that. It's middle of the night, 3 a.m. No, you want to talk to them and let them know. Thank you. That's all.
Yes, absolutely right. So the next is cultural norms. I think some of them has already taken care. I'll just give you my example. So when I came to US, I came with this culture that I know that handshaking is not considered very nice according to my culture. And then eye contact is the same thing. You don't smile to the stranger, but different countries have different parameters. And then the cultural norms kind of shift entirely. And it is different. You have to shake your hands. Of course, if the patient offers, and then eye contact when you looking at them, give a sign of you're respecting what they're talking to them, and of course a smile. So in the beginning, I was still on that scenario of not doing some of those, and I was doing like observership and some research work, and end up realizing people around me more smiley and more pleasant, and I'm more firm, and I'm not looking at to the attending when I'm talking. I'm looking around, and sometimes have difficulty pronouncing some of the words. Of course, I pronounce certain way, certain things, which is pronounced entirely different, certain other part of US. So the way I taken care of that is that I didn't put it on my ego. Oh my God, I cannot do that. But I trained myself, and I am. You train yourself by, keep working with yourself as a colleague of mine said, mirror, mirror. Yes, that's how it is. You train yourself every time you miss it. You tell yourself, I'm going to do it next time. And remember, it's not a big deal. You come from a different culture. I born in a different culture. I was trained differently, but that was the norm there. Here, the norms are different, and it is very pleasant to see how people are very, excuse me. Yes, how people are very, actively approach you, talk to you, look into your eyes. And when you train yourself more, you realize becoming more comfortable, and it becomes your reflexes, and you're not going to miss it. The other thing which I already mentioned, when you come over here, you're not going to talk to your patient like, oh, hi, how are you doing, sir or madam? And the same thing goes for your attending. You're not going to say attending. I know that was something nicer when you do that back in Pakistan. But over here, you're going to say, suppose somebody's working with me, then turn going to say, hi, Dr. Ali, good morning. How are you doing? And I'm going to like that. But if they're going to say, how, madam, how are you doing? I have to correct them. Okay, hey, call me Dr. Ali. And the patient, the same thing. Personally is the last name patient like to be called, but if you come to a scenario when the patient name is different and it's too long and you cannot pronounce it, try to pick up the first name. Or if you cannot pronounce first from last name, there are certain names are like that, then you smile, just say, hey, good morning, how are you doing? And you just escape that part. So go along with your comfort level, but keep learning, because learning is an ongoing process. Coding, outpatient. So during residency, I didn't realize that part was kind of very taking very less. When you start practicing and you do not know how to code, suppose a patient comes to me for physical, you charge it differently. When the patient comes to you with a medical concern, has a rash, blood pressure, abdominal pain, then you have to charge differently. Level 1 to 4 to 5, new patient, and then 1 to 5, old patient. Medicare is other charges, wellness visit is other charges, and post-hospital follow-ups are other charges. It's very important to talk to your attending, because when you go and tell your attending, this is the patient, they explain you make a plan, you go and discharge your patient from the clinic part, and you document, but the attending you said, don't worry about it, I'm going to code it and I'm going to charge it. Then you're never going to learn how you're going to charge your patient when you go to the real world. Take a proactive approach to ask them, hey, how did you charge it and how it's going to be? If they have someone who is give you training on coding, best. If not, then you have to talk to your attending every time and learn how to code your patient, because that will going to help you big time when you're going to be practicing on your own. Next.
So I think Dr. Malik has his hand raised.
Okay.
Yeah, so coming back to the presentation, because you will be presenting cases to the attendings in outpatient setting and an inpatient setting, is the same. You have to follow the format, eye contact. The best thing is try to practice. And honestly, like my program director, he made us record ourselves at how we're presenting. And then he made us watch like the video and look at like what corrections I can do. And that's when you say mirror, mirror, like you stand in front of the mirror and present the case. I thought like I was going right, but I was really dancing. I was moving my hands a lot, even now. But when I recorded myself and I saw it, I was moving my hands and just like, yeah. And then he looked at me and said, yeah, you're Malik, you're dancing. You're presenting and dancing. So but you don't know, like when you talk, you have expressions, your hand moves. So always, for presentation, a thorough, slow down, spell out each word, say every word completely. And if you record yourself, you will be the best critics. Best of luck. Thanks.
That's true. And then again, it is a learning process. You have to keep working with yourself. And it doesn't finish so during residency. After residency, still their scenario comes when I have to, I should have taken it this way, or should have corrected it in a way. Then I fix it for my next patient. So it's an ongoing process, and we all are learning. So you just continue working with yourself. All right, next. Okay, resources. We're already being told about UpToDate. That's your best buddy. And the APPNA, they both have apps. You can download both on your cell phone. APPNA are free, from my understanding is, and UpToDate given to by your residency. You're going to have your own login and password. When you have a time, you can read up to date in detail. But suppose if you're in the clinic, you have quick scenarios, you click the topic, click the summary, go to the summary directly, get your information, and then from there you can click and go to the detail relevant you're looking for. APPNA is more about medications. So suppose if you want to see which medication, okay, I want to prescribe amlodipine. Okay, what's the side effect I'm looking for? What's the interaction? So you click on that medication and you get all the medication interactions, dosing, kidney correction. And if any medication has a black box warning, then you will know faster. So APPNA is my go-to even now on my cell phone, and I use it quite a lot. And same goes to the up to date. So these are your best buddies long term until you're practicing. You have to use both of them, and as you use those resources, you will learn how quickly you get answers without looking back and forth. So keep using it, it will help you. So take home point is, residency is it, although it's a 3 years and it is dedicated 3 years, long hours, early mornings. As Dr. Malik said, you're not sure if you're going to leave by 6 o'clock or 7 o'clock, depending upon when you finish, but it's like a sprint. But after residency comes the real marathon, which means, once you finish, that's the time you have a hello of someone who's taking care of you. Suppose you can always run to someone and ask those questions you're attending, and you have this comfort that, oh, my attending told me so and so. But after residency, you are the one who's going to make decision on your own. You are responsible for your license. You are responsible for your decision making. And it's a long term. From there, what the path you're going to choose, you're going to be there for long term, of course. It goes to like inpatient or outpatient. So for example, for me as outpatient, the reason I chose was I was looking for after residency that I need a scheduled life, and I like to have my weekends off. I like to have my national holidays off. When I'm off, my husband is off, my kids are home, and we can have the same time. We can go vacation together. We are home together. Especially, I still remember my last day of residency, my pager, when the last time it rang, I took a picture and I said, I do not want anybody to page me. So for me, it was very important to have a structural morning life, and then no late night calls and stuff like that. So you have to decide when you're coming to that point where you want to see yourself. It is too early now. In the beginning, you're might feel that I want to be a nephrologist or I want to be in the ER. But as you're passing your first year, second year, and third year, you might change your mind. Eventually, by third year, you will realize where you want to see yourself, or you want to go to further specialty. For example, if you want to be going to be an endocrine, if you're want to be rheumatology and others. So decide what you're going to maintain with your personal life and how you're going to keep it on long-term basis. And of course, learning. And when you're not sure, you ask your attending in residency. But my point is, when you finish your residency, you're on your own. You are the one who's making decision. But whenever you're practicing in-house or outpatient, there are always going to be physicians who are practicing there before you join. So if some of those scenarios you're not fully sure how to approach it, or there's a question, you can always ask. For example, I practice in a bigger group, outpatient, and I'm practicing for quite a good time now, but still there's some question comes in your mind, then I'll just ask my colleague, like, if a 60-year-old female came with this and this, how would you approach that? Do you think this is the right, what you're going to do in this scenario? So you can kind of talk to the colleagues you have after graduation also, if you're practicing, take their point also, and likewise, they can ask you the same question on some of their scenario. They are not fully sure. So you can always ask, but at the end, you are the one who's going to make decisions after residency. It's easy for me to say, don't take work at home, but it's very hard. I have personal experience that people not able to, if you're not able to finish the dictation, you might take it home, want to do it. Try your best to finish all the dictations, all the notes in your time when you're in the hospital. Wrap it up, and when you go home, then it's your relaxed time. It's your catching up your sleep time. It is the time you want to spend with your family, and then of course some reading is there. sleep is must. The best thing is those who cannot drink caffeine. I have the same habit. I used to have tea. Now I do coffee, black, non-black. Caffeine is must for me. But the same time, if you're not able to do caffeine, the other thing is good sleep. If you sleep well, next morning your brain will be sharp, better than sleeping in 4 hours only. Taking time out for yourself, not the walking in the floors, but or during your rush hours, but if you have time for 10 minutes, maybe 15 minutes, few times a week, not necessary every day, go for a walk, listen some music, meditate yourself. Prayers, important part, of course, do your prayers, do things which make you happy. Just take out time for yourself, go out with your family. It's very important because it will help you to heal and recover, and you can perform better next day when you go for your residency. Next. And that's all from me. I wish you all the best. And if you have any questions, I can answer. Thank you.
So I don't have any questions right now here. All the participants, please post your questions in the Q&A section so we can pick it up from there. And towards the end, we can have more sort of an interactive session once we get done with the slides. Okay, no questions. And if there are no further comments from others, then I'll go into my section of the talk. So again, assalamu alaikum everyone. Good morning. I am Nauman Ashraf, work as the program director for general psychiatry residency and as well as addiction medicine fellowship program in Joplin, Missouri. And I will be talking about the evaluation and in-service exams. We'll also talk about some of the cases, real case scenarios, what had happened, why people got into trouble, so things you can avoid, and how to have like the best behavior possible during your training. So you start it and then hopefully you'll be able to finish it. So let's get through it. So when you look at the training, I always look at this chart, and I think Dr. Amnanas is going to like it from the child early development, but it's exactly just like that. So a child who they start off, say 6 months, 12 months, 1 year, they start giving you some social response, see some smile, they start to crawl, then walk, then talk and all that. Their milestones that they're achieving. Just like that, when trainees come and start their education, we have their milestones that they have to reach throughout all those, either it's a 3-year residency or 4-year. And initially they're anxious and reserved, and then you see them slowly learning their skills, getting more confident. And just like a child becomes more confident throughout their development, that's how the development happens with the trainee. There are 6 main core competencies that ACGME wants us to make sure all trainees achieve by the end of their rotation, and they are at least proficient in those 4 all 6 competencies. So those are medical knowledge, patient care, professionalism, practice-based learning and improvement, system-based practice, and interpersonal communication skills. So we'll break those down and we'll talk about it, but that's exactly what you have to do throughout your training to be able to have proficiency in those, so you can graduate at the end. And if you have issues in one of those competencies, that's where you get into trouble. And we'll talk about what happens then. There is a scale that we use. So what happens is you have a bigger competency. For example, take system-based practice. That is divided into sub-competencies. And one of the because in system-based, you are talking to other consultants, you are learning about how the system works, what are the other resources, disposition resources for the patient, but also you're looking at safety and quality improvement. So say one sub-competency is safety and quality improvement. And then within that, we will have small milestones to see if you meet that sub-competency, and then several sub-competencies will combine for the bigger competency of the system-based practice. So smaller ones would be along safety, along quality improvement. Do you know, or does the resident know how to report an error? So if something were to happen, some error happened that I think Dr. Hasina Ali was talking about, you made a mistake. What do you do? Do you know how to report? Do you know the reporting system? What do you do? How do you disclose it to the patient? So those will be the smaller components that we will look at and then assess your bigger competency. And it is assessed on a scale from 1 to 5. So the one is novice. You just started, you're very brand new, you don't know anything. That's how it is, and that's totally fine because you're in a program, you're gonna learn. What we want to see is over time you have growth, level 2, level 3, level 4. By the time of graduation, we hope every resident is proficient and they are at level 4. Level 5 is going to be sort of exceptional. It's like somebody who is a licensed physician and practice in the community. And a lot of residents do have level 5 on some of the subcompetencies and areas, but not on all of them. But our hope is that you start off at 1 and you show growth every year. And by the time you graduate, you kind of are around 4. You may not be in some areas, you may graduate 3.5, but most of the time you are at 4, 4.5, and some 5. In very few instances, somebody may start at level 3 or level 4. So suppose somebody who was a researcher and they were doing research for 3-4 years, they've got 30 plus publications, and now they want to do residency and they've MPH already. So they've had a research career. So on research subcompetency, they may hit level 4 right off the bat. That may happen in some of the areas, but overall, you want to see you graduate around level 4. So that's important for you to know, showing growth throughout your residency. So let's talk about and dissect these 6 main competencies that you'll be assessed on. It's patient care, right? Do you provide compassionate, appropriate, effective patient care? Now, that's a big competency. What are we looking at? How do you introduce yourself to the patient? How do you build rapport? How do you take history? How do you do exam? All those small components will go into that patient care. Medical knowledge. Do you have the basic medical knowledge to carry out the regular function? Even if you are taking history, you need the medical knowledge. When you are devising the treatment plan, you need the medical knowledge. The best objective measure we have to assess medical knowledge is your in-service exam. So it's very important for you to show improvement in your in-service exam as well. And we'll talk more about it. And then practice-based learning and improvement, which is evidence-based learning. And also when you learn about from the evidence-based stuff, how do you apply it to yourself to improve yourself? So do you read articles? Do you have your treatment plan? What you read? So there's a new study that came out, you read about something. Did you bring it and include it into your treatment plan? And in your discussions, try to show it to your attending, because your attending are going to assess you on these 6 areas every single month when you work with them. So if you can show them that you are good at patient care, which is they will be directly observing you, interviewing the patients. If you show your knowledge, which is reflected when you have case discussion, when you devise your treatment plan and your in-service exam, and evidence-based, practice-based learning improvement. Do you read articles? You talk about it in your discussion, include it in your treatment plan, and do you apply it to yourself to improve yourself over time? And you need to show that during training. The other one is a system-based practice. So knowing about the overall system, how do you talk to consultants? Do you know which one to call? You may be working in internal medicine, but you have a patient who has bad kidneys. You need to call nephrology. You may need to call psychiatry, neurology, other departments. How to initiate a consult, how to interact with other consultant. And if you have to consult another patient, how do you do that? Do you know about the resources, your system resources, where the patient is going to go? Suppose someone who is struggling with substance abuse, do you know the inpatient rehab, the outpatient rehab resources, where you're going to send them? And again, what I mentioned, the safety and quality improvement, extremely important, because it's all about the patient. We have mentioned it. If your patient is happy, you're going to get good satisfaction scores. That helps the hospital, and also will help your eval, and we'll get to it, because your patients will also do the eval on you. Professionalism, this is probably the most important one, hardest to remediate, because it has to do with long-term patterns that people have had, the way they have lived. So if I am someone who is gets short easily, on the angry side, it's very hard for me to change myself. So this becomes really hard, because somebody who has lived there 23, 25 years in certain way, and now they are in a program and they're having trouble working with others. How do you tell them to change themselves? How do they make the change within days and within month? And it's harder. This one is the hardest to do. And that's why it requires a lot of coaching, and you need to pay attention to your attributes, what you have, and if you have to change them. So you are required to have compassion, integrity, respect for others, responsiveness to patient needs that supersedes self-interest. What does it mean? So suppose you are on call and it's your birthday or a wedding anniversary and you have a dinner reservation, you have to give a sign out at 5 p.m. and then you go and there's a dinner plan already set up. You've invited 50 other friends and they're waiting for you. Around 4:55, a patient codes. You are there. Now you have to give sign out, but your primary responsibility is to take over the patient. If that code takes an hour, you have to be there for an hour to provide the care. Then you have to do a sign out to the incoming person who would be on call at night. And that would mean it's going to supersede your self-interest, but that's why we are in this field. That's the oath we took. Our patient care comes first, and you have to show that you cannot drop the ball and leave. You will get in trouble. So these are, and it happens in real life. It happens. I've had a scenario where I took over the shift from someone, and nurse called me after 30 minutes and said, hey, we had paged you an hour prior. There's a patient who was having some serious issues. Nobody came and saw them. I was not given the sign out. These things do happen. Please try to avoid them. Respect for patient autonomy, their privacy, confidentiality is extremely important. You want to make sure you don't talk about your patients with anyone in the elevators, in the hallway. The only place is going to be there are rooms for doctors' rooms, meetings rooms, on-call rooms in the hospital, behind locked doors. You can talk about patients with your colleagues, but not outside. Also, I would say sometimes people do not realize and they're making jokes, and patients can overhear and staff can overhear. So be very, very careful. Do not talk about patients and don't joke about them. And also don't do it about your colleagues and about nursing staff. A lot of people do not realize it and they feel like, yeah, I'm going to be fine and nobody would overhear me. But trust me, we have had those cases. Sensitivity, responsiveness to a diverse patient population, including but not limited to diversity in gender, age, culture, race, religion. We have talked about it, that you have to be respectful here. I think Dr. Amna Nasir mentioned, read about the gender identification. If people want to use certain pronoun, you have to respect it. Does not matter what you believe in, does not matter what your religion is. This is not the place to preach your religion. This is the place where you have to practice according to the standards of the US. People, and I have some scenarios and we'll go in depth into these, talking about issues around the age and gender and what issues that people have had, which unfortunately had to leave the programs because of these problems. So pay attention to it. Dr. Hasina Ali has her hand up. Please go ahead.
Yes, a quick input. When in terms of the respect and privacy of the patient, just remember the patient privacy means you discuss patient care with the patient only or with the assigned one. For example, if I'm your patient and I'm coming to talk to you and my husband calls, hey, what happened to Hasina? Can you tell me more about it? If I did not allow you or sign you that you can share my information to my husband or to my mother, you cannot share with my family members. It happened many times. Patient calls with their family members and get upset. Why you're not telling what's going on with my mother? And the mother says, I do not want to be discussed with my daughter, whatever their reasons are, this is their right. I had a patient who has hospitalization and the son came with the paperwork recently and demanding to be signed patient care under him, but the patient was alert, he was oriented, he was with himself, no memory problem, and he said he do not want his son to be next of kin, and he decide who going to be. So you have to make sure it's a legal thing. You cannot share information with the family members, with their neighbors, with their children without patient permission. Thank you.
Thank you, Dr. Ali, for adding that. So yes, also, whenever you take consent from the patient, if you are by yourself, I would recommend there's a consent form available on all the floors. Take that consent form. You will need a witness, and witness can be a medical student working with you, another co-resident. Have them sign in and then share the information, because there's some information that's protected, like about their substance abuse, about HIV, those is the status. So that information, you will have to take a separate consent for it. If you do not have the form, then make sure you have 2 or 3 witnesses in the room when you took the consent, and you document in the electronic medical record. I asked the patient to talk to this person. They allowed me in the presence of whoever. So you're protected legally, because they can come and say, I never allowed you. And what are you going to say then if you were the only one taking consent? Extremely important. And then again, yeah, people will call, friends will call. I want to know about the patient. Again, it's not back home. Here in the US, extreme patient privacy, so you cannot discuss anything. You just let them know, I do not have a permission from the patient to talk about it. I'll ask them and get back to you, and that's totally fine. When you are also when you're calling somebody in psychiatry, is very common. We tell our residents to go and get collateral information, ask the family how the patient was doing, if there was any safety concern. Medicine also, your attending may say, hey, can you get some information from the family? This person is how this person was doing. I think they're probably not sharing the information with us. Again, you need their permission, except for when it's emergent. When they're in the ED, there's an exception. Again, talk to your attending. They would know about the exceptions when you can call without consent. But for you, the rule is you always get the consent.
Yes,
So,
one more thing. Sorry.
yes.
May I?
Yes, go ahead.
Yeah, one more thing to be remembered in the in inpatient and the same time in the clinic. If you are a male and seeing a female patient, and if you're a female seeing a male patient, you have to make sure if you examining anything below the belt, like a pelvic examination for any reason, you have to make sure you have a staff present in the room. For example, I practice, so I have a male patient comes with so-and-so concern, and I have to examine pelvic area. I ask my nurse to be in the room when I'm examining, and I do document on exam part the staff was present, because it's very important in terms of respect, and it is kind of a baseline. You have to make sure you do that. Thank you.
And
Dr.
it does
Malik,
not have
you-
to be,
yes.
yeah, and it does not have to be a nurse, any chaperone. You say this is a female young patient or this is a male young patient, and I have to examine the private part, so I need a chaperone. So somebody who can witness it. That's I just wanted to include one point. The LGBTQ and the gender identity is very important. This is new for us as well. We got training modules from the hospital and the university to train on it. And now the electronic medical records, where the demographics is, where's the patient name and date of birth and medical record is, there will be a line that how this person goes with what identity, what name, or what gender. So it's so important that it's embedded in the EMR now, and it will flash or give you a flag that this person is identifies himself as a male and goes by this name. Just to add, thank you.
Thank you very much. Yep.
And also, I'm sorry, documentation on the chaperone. So Miss XYZ MA was chaperone. That should be a built-in EMR drop-down for you. Epic, make a drop-down. -- was my chaperone. So in case you get lawsuited, that person gets called in. Sorry, bye.
Yep. Great. Thank you. So the next competency is interpersonal skills and communication. Again, so that's one thing we will assess you on. It's important for you. Again, you are in the US. English is the language you will be using. So if you have any issues, hesitancy, please work on it. Take the courses, whatever you have to do, because if your patient gives a feedback that I cannot understand this resident, and multiple patients say, or this person has issues in communication and we cannot work with this resident, that you can get in trouble for that. So it's one of the core competency. You have to work on it. And also the communication skill, communication part includes how you document in your electronic medical record. Work on your documentation, need to know what needs to go in the documents. All hospitals have orientation guides. So you probably are already in touch with your programs. Get in touch with the chief resident. Tell them, please send me the orientation guide or intern survival guide, they call it. And we have one also. Dr. Malik has it. If he wants to share it in the chat, just a sample, so you can use that. But every hospital has it. Use that and see how they like you to work in that environment. Your attendings will let you know how they want their notes to be written. Most of these survival guides will include the SOAP note format, the HNP format, and the discharge summary format. And just learn it. Spend time with your chief residents and your attendings during orientation. It's always a good idea when you meet with your supervisor the first day, ask them, what are your expectations from me for this rotation? They will happily let you know, and then try to follow those. So that's one competency. And then let's talk about the rotation evaluation. briefly because we've got like 14 minutes. Okay. So you will be evaluated every month by your attendings on your rotations every single month. And there's something what we call a mid month evaluation, which is like an informal one. There are two ways. One is a formative feedback you will get from your attending. The other one is a summative feedback. Formative is they will give it to you right in that moment. So suppose you were interviewing a patient and patient said something about, I lost my family member, and you didn't follow the cue. And the next question you ask, okay, well, tell me about your sleep, how you're sleeping. You missed that point because that was an emotionally charged moment. You were supposed to take a break, pause, give that person a time to recover, and then at least say, I'm sorry to hear that, and provide the support. And that's extremely important. If you didn't do it after the encounter, your attending will let you know this is how it was supposed to be done. You were supposed to do it. That is formative right in that moment to improve that specific skill set. Summative is going to be when they have observed you for a month and then they say, okay, so these are your areas that's your strength. And these are the areas for improvement. This is where you need to work on. So then they can lump it together. In history taking, these are some of the points you can do. In interview, you can do this. Overall, everything is good. I think in knowledge base, this is the next you should do. Maybe sign up to this resource and read up on these articles. And they'll give you like an overall summary of where you're at, where you need to go, but not like a specific point. So that's a summative eval. The best idea is you meet with your attending at the beginning, ask them about the expectation for the rotation, meet with them at the midweek, like a 15-day, 16-day after the rotation, and say, I would like to get my mid rotation feedback. And if you can let me know what are the things I'm doing okay and what are the things I need to improve on. Why you want to do it? Because if you are struggling with some areas, that will show up on your eval. So you want to take care of it. You still got 2 weeks to go. So if you meet with your attending, they'll let you know, yes, you're overall doing okay, but these are some of the things I've noticed if you can work on. You got 2 weeks, you can work on them. So in the monthly eval, when attending puts down and evaluates you from 1 to 5, they can give you a level 2, and they were thinking about giving you a level 1. And in the comment can say that this person, this XYZ had issues initially around communication, but we met and I gave the feedback to the resident received the feedback well, showed improvement, and they are now on the track to move on to the next rotation. And that's great. That's an amazing eval that shows that you are able to learn, take the feedback, and you've already applied it towards your improvement. That's what I would suggest. That's the best way to do it. So you don't get into any trouble, and you also know how you're doing and get the timely feedback. How do you get feedback? There are different sources. There's ACGME uses a word 360 feedback. Everybody you talk to, everybody in your surrounding will be evaluating you. Your nurses, social worker, staff, your patients, your peers, your attendings. We get feedback from everyone. That feedback goes to what we call Clinical Competency Committee, CCC. That committee has a mandate to meet twice a year. So do a 6-month evaluation. And how do they evaluate? They take all this feedback. They look at your duty hours, log hours, and any complaints you have had and the in-service exam score, put it all together, and then come up with the suggestion whether this person needs some coaching. So they will give you the strength and areas for improvement after the 6 months to the program director and send it to the ACGME. Program director then meet with you. It's called a semi-annual eval and let you know these are the areas you're strong at, these are areas you need to improve. That's your chance the first 6 months. And if there is something serious happen around patient care and whatnot, then they may give you a warning and say, hey, you need to improve on this. Take those warnings, take those verbal counselings very seriously, because most of the time, as program directors, we understand you guys are coming in here, you're trainees, you will make mistakes. We are here to help you. So we don't want to write you up on the first mistake or second. We will give you a lot of verbal counseling and help you through that process. But if your attitude is, yeah, whatever, it's not written, it's fine, it's verbal, I have more chances. You may not have more chances, because even if it's a verbal counseling, there is some sort of paper trail there. Everything that you do is reported. You don't want to get to the point where it's a written meeting and you're put on remediation. The first time you're told about something, if you did it, you own up to it, you say sorry, and then you ask them, how can I improve myself? And try to improve and try to learn from there. And then there's an annual eval where Same thing will happen. All the feedback will be reviewed by CCC. CCC then will send the strength, areas for improvement, and another recommendation to the program director, which is whether this person is ready to be promoted to the next year or not. And that's important. If you are not in all 6 competencies, if you're not doing at the level where they want you to be, they may request a program director that this person is not ready to be promoted. Maybe we should extend the residency for 3 more years. Maybe they should repeat the year, or maybe we should not renew their contract and dismiss them from the residency. So take all these things very seriously. Again, you will always get a verbal warning. I think in most of the cases, unless you did something that was really, really bad along, like say harassment or severe patient care issue where there was a bad outcome, those are the things where people get dismissed right away. But in a lot of situations, they get a warning. That's your first and last chance. You need to take it seriously and improve. Okay, so we'll get into these scenarios, and I want everyone to join, and all the panelists, if they want to turn on their cameras, and let's see if we have some more people from that we want to join, if they can. And I want to go through these clinical cases and vignettes. So, and then you guys can chime in, and let's see if there's a question we can take. And then, so, okay. So there's a question, let's take that and then get into the cases. So hypothetically, if a hospital or department asks you to wear pride colors attire or attend a pride event, do we have the right to respectfully decline? Of course, we would use the proper identifying pronouns on patient encounters, but do we have to align ourselves with the pride event and movement? And I know I'm not sure if a hospital is going to ask you and go all out that you have to do that. Dr. Amna Nasser is on the camera. Dr. Ali, do you have any comments on that? Yeah.
We had this issue, we had to stand by one of our very Christian Orthodox residents, and it is our residents' right to their views. May they be LGBTQ aligned or otherwise, and they are allowed not to participate if they wish.
Right. But the department is not going to make them do it, right? Their question is the department is asking you, which is not true. Yeah. They would never do it.
It was a parade, and at the parade, everybody wore rainbow colors and whatnot, but the physician wore white or one color, and that was fine.
Right. Yeah. That should always be fine. Yeah. Okay. So first,
yeah, you can always support and participate, but you don't have to wear colors and clothes. Just be respectful for them, like what they believe in. That's what it is. Yeah. You don't have to agree with them, but you have to respect them and show them support, because this is where it is going, that we have to support them.
Right.
Right. Yeah. Okay. So the first scenario is CME conference. So these are all real scenarios. There was a resident who what he did, he found out a conference which was not like one of the main national conferences. He wanted to go there. All residents have some sort of CME or educational funds you can utilize once a year. You can go for a conference. And what he did, he submitted the conference with some dates that it's happening, say in Chicago, I want to go there. So the program received that, and it seems like it's an email that has the dates and everything. The department approved it. The resident went. And the program director somehow had a gut feeling, I don't know about this conference. It's a new conference. Let's find out. Maybe it's interesting. So let's check it out. They Googled or reached out and found out that this conference had already ended a month prior. So the resident had photoshopped the dates and submitted the wrong information. And they had to let the resident go. So do not do that. You cannot lie, cheat. You just it cannot happen. You're a doctor. In this situation, you just cannot do that. Any other panelists who have anything to share on this?
Yeah, so this is considered as a fraud, right? So fraud in any area is not acceptable, especially being medical professional. You have to make sure it's your license. And if you're doing anything fraud, for example, documenting wrong about your patient, charging them wrong, or CME, like after graduation also you get CME. So we still get the CMEs. We go and attend those CMEs with the current times, current locations, and then you submit it. But if you're falsifying the information and consider fraud, it will bring you trouble. So don't do it.
Yep. Like the APPNA conventions. So remember, the APPNA conventions have dinners, there are singers, there are concerts, but there is a CME. And you have to get to those CMEs. Those CMEs are AMA and AFPs accredited, and you get CME points. So if you want to go to APPNA, you have to go in the morning to the CMEs as well. Bring education, get those certificates, and then you can enjoy the dinner and concert too. But show your professionalism. This date and altering dates and having visited Hawaii and exotic places is not acceptable.
So my rule of thumb is that always go to the professional known conferences. You don't have to find something in your hometown to get 4 or 5 days free and visit your family. This is not the time. See, you have struggled very hard to get to this point all your life. You don't want to mess it up with these like small things and ruin your career. So always go to the big conferences and utilize the funds and get education. Like that's what it's for. Okay, the other scenario is I was attending the ACGME workshop and they had it. There was a resident, and it's back in the days, like they were talking about like 30, 40 years ago. They used to have TV in the call room, and back then maybe people didn't have TV in their home, whatever. He was watching like a soccer game and his call ended. So he decided to take the TV with him to his place. So, and he thought it would be fine, but the security saw it on the camera, and the next day the questions, and this was the situation. So they had to let the person go. Again, cannot take anything. We talked about taking your office supplies home. You cannot. I mean, some of the stuff, if you need, just talk to your coordinator, talk to your program. You need a pen, you need a printing paper, you need to print off something. Those should be fine as long as you have a permission. But without permission, cannot take anything. The common scenario that happens is taking books from the library. You're allowed to take it, but there's a date to return. Some of the people will take it and then they don't remember, and then they graduate and they're looking for books. Very unprofessional. So just try to avoid it. You will have your book funds. You will have enough resources in the residency to really have these things otherwise, access to them. Changing medical records. So a lot of time residents, and we all make mistakes, right? Something happens, there's a bad outcome, not really bad, but you gave a different medication than what your attending wanted you to, or you did not follow through something. Now you go back and change the record. Never do that. A, it's not a good thing. B, these are all electronically signed. This is EMR days. You cannot go back. You cannot change the record. One of the reasons we moved away from paper record is so there's more accountability. So never do that, never fudge anything. Any comments on that, panelists?
Yes. So coming to that point, during my training, I come to know there was a case. There was some paper charts, some electronic at that time. And then one of the case was that there was a lawsuit on some patient. So once there's a lawsuit, suppose it's an ex-patient, ex-medical record, never go to the chart to look into those records, never go to the chart or even the paperwork to change it, because the medical record, once anything is filed, everything is on alert, everything is documented, everything. If you try to get those records and try to change anything, and it's already going under legal thing, you may or may not be part of it, is going to be a big problem. So yes, do not change anything, especially that case, the charts were sealed. Because I was doing a case presentation and giving so-and-so scenario, then come to know that patient died, something happened, and their charts are sealed. The patient was not mine, but I come to know that when there's a lawsuit or anything, unexpected death, the chart being sealed and under investigation. So you should not be going in the direction on looking into them or making any changes. So it's again is a legal thing. So be careful. Yes.
Yeah, you guys will be trained on HIPAA compliance, the Privacy Act, and remember this. It's so strict. I'll give you an example. I was traveling and I had to show them COVID vaccination. So I went on Haiku and opened my chart, showed them the COVID vaccine. And when I came back, I was dinged that I went to my chart. They said, if you want to go to your chart, there is another portal, which is My Chart Haiku. You can go through that, but you went through the doctor's thing. I said, it's my chart. It's like, yeah, it's your chart, but you cannot log in through the Haiku. You have to go through the patient portal. So it's that important. And I was dinged and I have to write an explanation that why I access my chart as a physician through the physician portal, not the patient portal. So it's that important.
Right. So next scenario is lying. Very common. You are on call, and if it's an in-house call, you're supposed to be in-house. Now there are some exceptions, people need to go get lunch, but that's like you go grab a lunch, come back and you eat it. If it's not available, say in your cafeteria, it's middle of the night, nothing is available. 10, 15 minutes, you do a run and then come back, you have your pager on. But a lot of people leave and then they're lying. There was a scenario where somebody was rounding like over the phone rather than just being physically there, not seeing patients, leaving, asking your colleagues to cover for you. It may work for a month or two, but there'll be a point your colleagues will complain about you. So do not think that this is going to be okay. Like you're supposed to be here, say on a shift from 8 to 5, and your work is done at 1 and you want to leave. Rather than informing your residency program, you just tell, hey, don't let the residency know. Can you please cover for me and I'll be back in 2 hours. Don't do those things because that will fall under professionalism. And again, if something bad were to happen during those 2 hours, there was a code and patient had a bad outcome, it's going to be on you. You will be written up. So you don't know, you don't tie up what can happen. There are rules in place for a reason, and just try to respect them. Anything on that? Okay, so the next one was checking the health records. Dr. Malik already talked about it, checking your own, but also if it's not your people, even go and find out about their kids, about their family, about their neighbors. My friend got admitted. You are not the assigned doctor. You should not be touching that record. The minute you log in, there will be a notification that'll go to the compliance office. And just like Dr. Malik, you will have to write an explanation. Now, he is an attending, you are a resident. So in a very different board. So think about it, how you would be dealing with it with the compliance office. So never touch anything that's not assigned to you. Now, sometimes there's a mistake. You're trying to go in one patient chart and you by mistake click on the other chart. The minute you realize, come out of it, because they also look at the timing. So they may question you, hey, why were you in this person's chart? And you can say it was by mistake, and you can see it was just for 5 seconds. I realized and I came out of it. So do not read anything in patient chart, but you went into wrong patient chart and now you clicked on their history, then in their social history, then their medication. That's not a mistake. Then you were curious, and everything, again, everything is time stamped. It's a different era. Everything is recorded. So please avoid those things. Yelling and misbehaving with other colleagues. If you have a temper problem, you need to know you cannot lose it. A lot of time it happens on consult. So you have done like a long call. It's a 24-hour call in-house, suppose. It's like the 21st hour and you're like it's early morning, somebody calls you, they want you to come over and see a patient for a consult. And maybe they were not nice to you. They were a little bit rude. Now you lose it on the phone. The other person was calling you is attending, maybe not that nice, but you are a resident and you misbehave with them. Next morning, your program director will definitely get a complaint. Your HR may get a complaint too. So be careful. You have to be at your best behavior. There are instances where other people may also talk to you disrespectfully, and then you let them know that you will talk to your supervisors. You send an email to your program director, and there's a way to report those nicely, but you don't need to yell back at them. Racist, sexist remarks, jokes about someone's age, very extremely important. You cannot do that. Coming from Pakistan, we know our like the literary culture and literature is all filled with jokes about women. All our poetry is about that. You can't do that here. Like if like 5 men are sitting around and making jokes about like on wives and women, you may have heard it back home and somehow it's tolerated. It's not going to be tolerated here. You cannot say anything about it. Again, about the about anyone's age, whether they are old or not. You cannot say anything about it, that they are having difficulty walking because they are old, or they've got arthritis going on because they are old. Not supposed to comment on age. Just avoid those conversations. Avoid religious conversations, about political conversations. There are other areas that you can comment about. You can talk about. Sports is a good area. Food is a good area. Weather is a good area. Visiting places, tourism. Find those themes that people can connect you with, and that's where you can make some connections with them and you can talk with them, but avoid these areas. This is a very sensitive areas, and you should definitely read up on it, and I'm sure all the hospitals will give you training. Take it seriously. Any comments?
Even physically, like if you tell someone you're obese or
Yes.
overweight, you can't use the word fat.
Yeah.
And even though like there is a morbid obesity in US, but you can't tell them. They'll say my knee hurts, my this hurts, and you can't tell them you're fat and you said your weight is high, or you come into this BMI, or you're morbidly obese. They are different terms and words. And even identifying that this patient who's fat or who's, so you have to be very carefully when it comes to even identifying something physically. If it's very skinny, you can say petite, or you can't say you're skinny or you have your skin and bones and stuff like that. So race, color, physical appearance, it has to be dealt with very careful. The words are very important when you use it.
Right. And it's not like back home, if someone is friendly with you, either the staff member or your colleagues, it doesn't mean you can joke about anything. There are still those boundaries you have to follow, even if they are really good friends with you. Dr. Amna, you had something?
Yes, I have just a lot of people have asked questions about anonymously about sexual advances. And I think it is very common. So I just want to present three not vague, but tangible ways to deal with it. Because, you know, we all hear something happens, you're not comfortable, do something. Okay, well, I'm going to tell you personal three things. You make a phone call. My resident, this happened, was on with me. I made them call for a bleeder to the ER. ER doctor says to her, where are you from? She goes, oh, I'm from the East Coast. He goes, oh, so your blood runs red and your undies are blue. Okay, she talked to me and she was very uncomfortable, but it's a phone conversation, no witness. So we were kind of perplexed. Of course, I spoke to the program director and then that person spoke to the ER. But you need to talk about that doctor. Hey, Dr. Zander, not his name, Dr. Zander, you know, he's kind of a sexist. He makes feminine remarks. So these are microaggressions. Put that out in the world. Talk to the nurses, spread that vibe about him so he hears it. Then in the OR, somebody says, tie it up like you tie your husband. And that's when you need to have something ready to say, doc, young female or male doc. It could happen to a male doctor. Say something like, ooh, that's hella inappropriate. Ooh, that's very inappropriate. You have the culture is they'll ask you, did you say something to the doctor when you felt uncomfortable? So have 2 or 3 lines ready, my female and male doctors. Ooh, that's very inappropriate. So the doctor gets attention that you find it inappropriate. Or a doctor asked on that comment, they say, hi, beautiful. Happens all the time. You say, it's Dr. Beautiful, actually Dr. Nasir to you. And if a dad tries to say, beautiful feet, you say, hey, it's Dr. Nasir to you. So then you just bring them back. That should be step 1. And step 2, you report it. And always have a couple of lines ready because we think about saying things later when we get home. And reach out, email me if you have more questions.
Great. Thank you, Dr. Nasir. And then Dr. Ali wants to share something.
Yes, the kind of similar is that suppose it is happening to you, you respond the way Dr. Nasir said, but suppose a different scenario, they are in the hospital and the clinic setting, if the staff is sitting and gossip about one of your patient or the other colleagues are gossiping, do not participate. They joke about something and then look at you, then just you smile or walk away. Or the better scenario, as Dr. Nasir said, you said, oh, okay, that doesn't sound appropriate. So you respond this way. Do not jump in and participate. You're right, this patient is old, or you're right, look at the dress, or you're right, this patient's too fat. No, you respond in a way that shows that you do not participate in that, and by saying, okay, this sounds inappropriate. So yes, do not participate if someone else is doing it and you're walking through into that scenario. Thank you.
Yeah. So the next scenario is calling in sick, and then the social media scenario. So you are on call, scheduled to be on call. In the morning, you call in sick and you say you're not doing good. But you know, that's it's the social media age. Then later in the day, after 2 to 4 hours, you are in the mall or you're having fun and you're posting all the pictures on your Instagram and your Facebook. People would know, your program would know somehow. And we have had these instances. So the story will come back. So again, don't lie. Just be honest. You have worked so hard to get to this point. Why ruin it? I don't understand. Why do people do it? So it's just 3-4 years, get through it. And then you'll be attending, you'll have a degree at least. But if something were to happen, God forbid, in the middle, then you are hanging. And people may think, okay, if I let go of this program, I'll find a spot somewhere else. It's not easy right now. The spot is the bottleneck. You have too many positions open for doctors after you graduate, and tons of medical student trainees who want to get into residency. You don't have enough residency spot. You may not find anything. So very few, like if 10 people are dismissed, maybe 2 or 3 are able to find something. 6 or 7 have to then change their careers. Do not do that. Just, yeah, plain. And Amazon book scenario, a lot of residents, what they do, if there's a book fund, they'll say, oh yeah, I want to buy books on Amazon. These are the books I bought. This is a receipt. They get reimbursement, and then they return the books. You can't do that. This is, you got the money for the books. I know you have 15 days, 14 days, whatever for the return. But if you got reimbursed for something, for educational, you keep it. Now you want to exchange the book, you go back to program, let them know, hey, I'll be exchanging this book for another book, make it kosher, and send them an email. That is fine. But you can't just get the money for the books, and then after 10 days, once you got the money in your account, go and return it. Communication issues, I think I talked about it. If there are things that happen, then, and you are given some warnings, you have to take those warnings very, very seriously. So a lot of people have had this problem. Again, falls under professionalism, and they have to do with their personality, how they were raised, how they lived all their life. If you never held a job and you were pampered, this is going to be tough for you. This is not easy. Internship definitely is not easy. You are lowest at the totem pole. People will be giving you orders. If you cannot take that, if you're not a good team player, you will run into troubles. So that's a skill everyone has to develop. You need to pay attention. If you have hard time working in a team environment, that's something you got to do. Maybe do some volunteer work before joining residency and see how you work with others, how you work under different leaders. This is extremely important. A lot of time people run into trouble because they're not a good team player. They just can't work with others. And it's not much we can do. These are hardcore characteristics, attributes, and it's hard to remediate, unfortunately. Okay, well, let's open the floor. These were the scenarios I had. Anyone who has anything to share, I'm going to stop my screen sharing. Or any of the participants, if anyone wants to come live, we can allow them to talk. They can turn on their camera. We can take questions. Okay.
I guess we covered everything. So this is not the end. We will send you over emails. You can ask us questions. And this doesn't end here. Once you start your internship, I'm pretty sure there'll be more questions and questions. Pick an advisor. In those attendings, you will be assigned an advisor. That's the best person to go with. And that advisor will help you to understand any questions you have on the floor on the action day. But if that advisor is not interested, APPNA has some advisory boards. There are different volunteers who can help you if that advisor is not helping you. But pick an advisor in your attendings. And if you have any issues with personality, conflict, team player, go talk to them, and they could be a big resources and they can help you with that.
Yeah.
And my step is you can change the advisor also. Suppose if you're attending and we are not on the same page and you need more help and you feel like my other attending is more seems like helpful, I'm getting more answer, you can always request to change. And sometimes they give you like a senior resident also, your third year going to be as your mentor, going to guide you some of those stuff. So you can go to them, or it maybe change depending upon program by program. Yes.
Yes, so I'll second that what Dr. Malik was saying. I think anytime you have any issues, somebody talks to your chief resident, your attendings, and you think that there's something that serious that you need to work on, reach out to your mentors, reach out to APPNA YPC. We have counseling available, so somebody can help you out. You also have your alumni network. So one thing good is if you are engaged with your alumni, and one way would be to join APPNA. I think the membership is free. So you can join as an in-training member, be part of your alumni. Your alumni has programs. We got several alumni people here. So if you reach out to us, we can connect you to our respective alumni. Every alumni has some sort of YPC, even if it's not official. There are 2 or 3 people who really want to help and mentor young trainees. So they will get in touch with you. They can help you out. So we want to say that the help is available. The support is there. You have to reach out, be part of this network. Another thing that you have to do is internship is very hard. You will have calls and we know the night float weeks are horrible. If you are there for a week or 2 weeks at a stretch, you won't be seeing anyone, you won't be showering, you won't be doing anything. It's very tough. But when you get a time, connect with people, just keep your support network intact, your family, your friends, your other friends that you make, again, this alumni, talk to them, reach out to them, spend time with them. Your wellness is extremely important. There's a 50% chance of having burnout during residency and residence. So you want to take care of that. And at some point, you may get to that point where you experience burnout. We all go through it. You need to learn how to be resilient. You need to know the coping skills, how to come out of it. And your support network will help you with that. Okay, any last minute comments? Okay, great. Well, it was wonderful. We organized this webinar. APPNA YPC did it in collaboration with St. Louis, Missouri chapter. So I'm really thankful, grateful to the St. Louis chapter, Dr. Malik, Dr. Nasser, Dr. Ali for joining us. And again, congratulations to all the participants who have been matched. We wish you good luck. Please reach out to us. You can join APPNA YPC page. You can join APPNA organization through their website, and it's also the membership form is on the YPC. Be in touch, and if you need any help, please let us know. And
Thank you so much.
Rest of the weekend. Yeah, thank you.
All right, thank you, everyone. Thank you so much.
Thank you. Good luck.
Bye-bye. Good luck.